Recorded. All right, there's a record button now. Thank you everyone for participating in this educational series for August. With us today from the Michigan Health Information Network is Joanna Jarvie, Senior Director of Outreach and Marketing and Communication, and Megan Gibbs, Director of Customer Service. And they are from the Michigan Health Information Network again. We're going to go ahead and I'm going to turn it over and get it started.
Hi, everyone. Megan, so I think I'll start and then I'll pass to you.
Sounds great.
Hi, my name is Joanne Jarvie. You can see me. I am going to go off camera now, though, because it's just easier for me to not be on camera. I hope that's okay. Thanks, Jeff, for the introduction. We are here from Michigan Health Information Network, MICAH. My name is Joanne Jarvie. I am the Senior Director of Network Growth and Development, which is really outreach and communications. And this is a presentation for you all. And we want to make sure that we are answering all of your questions. So we want you to be as engaged and sort of as in it with us as you can be. No, there are no, there are no dumb questions. This may be the first time that you're hearing about MICAH. It might be the 17th. I learn something new every day. So please feel free to come off mute, ask some questions in the chat. Thanks, Jeff, for monitoring the chat. And we'll be on our way here. So let's see. Next slide, please. So here were the learning objectives that we put together for you all. And if you find that you have another one, or if we haven't covered it, please, hold our feet to the fire. We are going to really do some high-level explanations of MICAH and our Michigan's statewide data exchange model, how the data flows through our network, the roles of our various stakeholders, how the data is utilized through and within the HIE, how it's accessed, the roles of end users in the data exchange process, understanding why it's important, understanding it from a data quality perspective, and then understanding how and why you all participate. So next slide, please. MICAH. MICAH is a nonprofit organization. We exist between powerful sectors and stakeholders within the healthcare ecosystem. We are not owned or controlled by any one payer, by any one hospital, by MDHHS, by any one government. We are a nonprofit organization that sits in between very powerful, very important companies and sectors. And our job is to securely and technically exchange personal health information. We are an unbiased data trustee. That means that we are a neutral data steward. We do not create any of our own data. We don't produce any of our own data. We are charged with making sure that data is exchanged for certain purposes under HIPAA. And really our role is to continue to act as that third party to make sure that everybody gets a say in how and why they need critical information to run their businesses, to take care of their patients, or to understand more about their operations. Next slide, please. So here, this is just a sort of a visualization of, who is exchanging data within our statewide data exchange. We are the infrastructure, the technical infrastructure, and the underlying legal infrastructure for sharing health information between health and hospital systems, the state of Michigan, behavioral health clinics, primary care clinics, pharmacies, home health, long-term care providers, SNFs, lab and radiology companies. Our job is to make sure that we are that the data is flowing between and to all of these different entities. Next slide. So what's our goal? Our goal is to exchange health information for these purposes, to reduce inefficiencies, to improve healthcare access, to help lower healthcare costs, to create a better quality of care and health outcomes. And in the future, and as we get more quality data and better and more specific demographics, we are working towards personalizing the care journey for each human being. This is why we exist. We believe that the private, secure exchange of health information brings about these outcomes. And this is why we do it. What do we mean when we say we're doing this sort of as a network? Well, we have around 45,000 care providers who are exchanging data with each other through our network. And this means that we have records for about 13.1 million human beings. This means that there are different levels of information sharing. We are sharing information between health payers, between health systems, between PIHPs. You're going to hear me say the same things over and over again, between hospitals and clinics, CMHs, hospices. But ultimately, at the end of the day, it's so that dentists and doctors, care managers can see information that they need to make better care decisions for their patients. MICAH is exchanging data between all of these players. Next slide. Again, just to give you a sense, we have 158 hospitals and 77 home health, around 320 and growing every day, SNFs, and 707 outpatient facilities that are contributing admit, discharge, transfer notifications as one data flow to our through our network. This is I wanted to make a distinction. So we exchange bi-directionally, which means that people send us data and we send them data. We are the pass-through of data to MDHHS, to Michigan's Health Department. Next slide. Okay, so again, another visualization, like why is this necessary? Why does MICAH exist? Because if there weren't a hub like MICAH that was a third-party nonprofit organization, each of these different providers and systems would have to create their own one-to-one exchanges. And it's just not an efficient model. And if it were that way, then maybe data would be lost. Maybe there would be specific instances where, they just couldn't get the data to flow. And here we see that if we have a hub and all of these spokes, the hub creates the connection once and can use that connection for a multitude of other connections. I don't want to be moving too fast. And this is sort of, if you've never heard that something like this exists, it might be a lot to take in. At this point, does anybody have any questions sort of about what MICAH is, why we exist? Great, moving on. Okay, so you use a health information exchange essentially to send data to receive data from, or to find data within and use. These are the four functions: send, receive, find, use. And so one of the questions to your mind could be, do you know what data you are sending MICAH? Do you know what data you could be receiving from MICAH? And do you know what data is there for you to find or to query and to use for treatment, payment, or healthcare operations? This is what we would want to find out for every single one of you, and to make it clear to you what data you are sending, what data you are receiving, what data you can find, how you're using it, and why. So, as the data flows, sometimes people get the data and they go into their source systems, they go into their EMRs or EHRs, and the data can flow directly into those systems for these patients. And sometimes, for many reasons, entities prefer to use tools to send, receive, but mostly find and use the data that's flowing through the network. MICAH has a sort of a list of products and applications that help healthcare entities send, receive, and find all of the data that is flowing through the network from all of these senders. And they include tools like My Gateway, Care Convene. We help you to set up a direct, secure messaging system. We have an underlying infrastructure that helps payers meet all of their compliance, meet all their compliance needs. And we also have a very robust statewide network for referrals. One of the main questions that we wanted to make sure that we explained was, I think it was on, if you go back to, you don't have to, but I'm going to just read out loud. Part of those learning objectives were discuss how data flows throughout the MICAH network and how it's utilized, including how it's accessed. So one of the like the core of how we exchange data at MICAH is through a framework that we call the active care relationship service. Okay, we have the ability to map each human being, each patient, back to the providers who are caring for them at any one entity. So the way that we route data at MICAH is patient-based. We send data to those providers who have an active care relationship service with the patient. And this is happening 1-to-1, 1-to-3, 1-to-5, depending on how many of a patient's care team members are connected to the network. So if you are sending us data, that data is being exchanged legally, securely, and technically to each member of a patient's care team who has the legal right to access that data? Does anybody, we're going to dig in a little bit here. Active care relationship service. Okay, next slide. So why is this important, right? This is important because it stands as the sort of basis for how and when and where we route data electronically, but also, again, what is the legal right to access that information by the receivers of that patient data. So if we know who the information or the data pertains to, if we understand who the patient is, we have a map of all of those patients' active care relationships. And the data is routed based on those relationships. The active care relationship supports our legal chain of trust, which means the way that entities can legally exchange information with us. It supports, it is sort of the underlying way for us to enact the HIPAA privacy rule. Under the HIPAA privacy rule, data can be exchanged for the purposes of treatment, payment, and healthcare operations, quote, for patients whom entities have in common. ACRES is the map of who and of the patients that entities have in common. The Active Care Relationship Service directly supports CMS's conditions of participation compliance. The conditions of participation for sending ADTs is that the notifications should go to patient care teams, and a care team should receive healthcare alerts on that patient, which enhances a hospital's compliance with CMS requirements. To be clear, really quick, going back on that, MICAH is not overseen by CMS, but everything that we build and everything that we do is to make sure that the participants on the network, those entities who are legally sharing through our network, can meet the requirements of CMS by participating in our network. Next slide, please. So just a quick, again, a visualization. Okay, so the hospital sends us patient data. And when the hospital sends us patient data, that means they are reporting that they are now, in an active care relationship with this patient. Okay, they have a relationship. They are serving this patient. That data gets sent to MICAH. MICAH takes it into our system, and we say, okay, who is that patient? Who are the active care relationships for that patient? And how do those entities or those providers like to receive or retrieve, find, or use the information for that patient? We then push the information to those that have an active care relationship with that patient, or make it available for finding. We send proactively and or make it available for finding and using. So, when we're going through this, who does MICAH benefit? Who are we serving? Well, we're serving, at the end of the day, we exist for human beings. We exist so that patients can be engaged comprehensively by all those who serve them. We believe that when people have the right information at the right time, they can make better decisions about their patients. We believe that patients should not have to tell their story or to give their information every single time to every single provider. We believe that they can be known and be served as a known entity. Next slide. We enable healthcare providers to have a comprehensive view of that patient's medical history, which we believe allows for better care coordination and more improved treatment. We exist so that you can spend less time requesting and waiting for medical records from other hospitals or other care providers that are responsible for also serving this patient. You can be connected through MICAH, and you should be. We believe people and providers can be more informed about their patients' recent hospital visits or who they are interacting with in the healthcare ecosystem. We believe you can use our network to manage high risk and complex patients with more informed care coordination. And again, really enhance care management and follow-up activities when you are pushed critical data about your patients that you could never have known unless you wouldn't even know to ask. But because our technology is mapping you to these patients, when they go to the hospital or when they go to another provider, you can know, and maybe you should. The next slide. Similarly, there are public health initiatives that are there to improve healthcare outcomes, reduce costs. And when we share information about a lot of people, government entities, health departments, organ donor entities are more able to use that data to serve and protect. Next slide. Payers. MICAH also helps payers streamline claims processing, reduce administration costs, and provide real-time access to patient data for purposes of payment. Next slide. So just to give you a sense, by participating in MICAH and by exchanging information through MICAH, you are able to meet the Medicare Promoting Interoperability Program objectives and measures through the Health Information Exchange bi-directional exchange. And also when you submit syndromic surveillance, immunizations, electronic case reporting through to MDHHS and to government agencies. We also support public health registry reporting and clinical data registry reporting. I'm going to stop there for a second. It's a lot. Just wondering, I'm going to come on real quick. Is this new information to anybody here? Is this something that, have you learned anything new today? Yet?
Yes, this is all new information for me.
Okay. Is it like coming together, like are you able to visualize it yet?
Yes, I think so. Yeah.
So everybody uses their own.
Does everybody participate in this, or just certain practices or hospitals?
So we have 98% of the hospitals in Michigan participating.
Okay. Okay.
And really, those that aren't are some of your Insight surgical centers and then the VA clinics. Though we've been targeting them for years, I think there's just some nuances there, especially with the VA, but majority of the hospitals and health systems in the state of Michigan are participating and exchanging data through the MICAH network.
Okay. And It's just everything goes into this, like labs, notes, everything. Okay,
That's correct.
all right. Pretty cool.
We think so. It's cool and it's also highly regulated. And the more we advance, you'll see, we believe, the more it will be patient driven. And MICAH is set up for that because of how we built our infrastructure. So let's dig in a little bit more. Maybe look into beyond just caring for patients and having access to all the information you could really that you need to make really good decisions about their care. There are also operational, and business reasons to participate with MICAH.
All right, let's dive in. So hi everyone, Megan Gibbs. I am going to turn my camera off since I already got one error already from Zoom. But I'm going to talk to you a little bit more about the importance of the data exchange within our network. I think most of you might be familiar or at least have heard about Blue Cross Blue Shield's P4P or Pay for Performance Incentive Program. I know that this is probably one of the more well-known incentive programs from one of the health plans across the state. I do believe HAP has their own, and each of them has their own nuances. But the big one that I wanted to talk about today is the Pay for Performance initiative through Blue Cross Blue Shield, which I believe all of you can take advantage of. And I would be happy to connect with you or even connect you with a representative from Blue Cross to learn more if you're very unfamiliar with their reimbursement program. But Blue Cross Blue Shield's P4P initiative has been around for several years. I remember it was one of the key concepts I was working on with our health system partners many moons ago. But Blue Cross has recognized that there are different capabilities depending on the size of a hospital and or health system. So what they have done is divided out our hospitals and health systems into two separate peer groups. Peer groups 1 through 4 are going to be your large and medium-sized hospitals. So those would be like your DMCs, your Henry Fords, your Ascensions, your McLarens. But where most of you probably fall into the category is that peer group 5, which is your smaller rural hospitals. That's not to be, I think, anything less than your peer groups 1 through 4. You just have somewhat different requirements. And that's, I think, a good thing, to be honest. But up to this point, the P4P program has paid over $200 million a year to the hospitals that are participating in the incentive program. And the HIE portion, where MICAH comes to play, of that 200 million was just over 42 million back in 2022. So MICAH doesn't have the ability to speak on how much incentives your organizations might receive or what the total incentives that your organization should receive, so and things of that nature. But there is significant money being paid back out to participating organizations within this Pay for Performance initiative. So while that 42 million was spread across peer groups 1 through 4, this does not mean that peer group 5 can't participate and or can't receive incentives, which I'm going to dive in a little bit here. So the P4P program has 2 hospital incentive-based programs. So I'm just going to refer to it as P4P, but know that I'm talking about the Pay for Performance initiative. And again, reminder that their programs are separated between peer groups 1 through 4, and then also your communities, which would fall in line with peer group 5. So again, your conformance requirements are very different than the other peer groups. Peer groups 1 through 4 are required to not only send the data, but they have to adhere to strict requirements as it pertains to how often those messages are populated with specific segments, and then making sure that the data is of good quality content. But more specifically for peer group 5, there are 3 different measures that organizations can participate in. The first one is transmitting ADT notifications that meet data quality conformance. So that's basically sending your ADT notifications through MyHIN, so MyHIN can share those ADTs with members of the patient's care team. The second is sending CCDA data to MyHIN. So similarly to ADTs, we want to receive those CCDAs so we can route them outbound to members of your patient's care team. And then lastly, it's transmitting lab result data to MyHIN for same purposes, just like ADTs and CCDs. So you'll see that there are variations in the total points available, ADT being your largest one. But so long as your organizations are contributing this data on a quarterly basis, you'll receive points for that measure. And to be a little bit more specific based on what some of those nuances are, you'll remember where the first requirement for transmitting ADT notifications was not only just sending the ADTs, but ensuring that you're meeting data quality conformance. So the peer group 5 requirements are lapsed from peer groups 1 through 4, but for ADT notifications, Blue Cross Blue Shield is focusing on complete routing, complete mapping, and adherence to coding standards. So as part of complete routing, that's capturing your patient information. A couple of things like first name, last name, date of birth, gender, address, things of that nature. When they mention complete mapping, some of you might be familiar with what MyHIN calls an ADT 2.0 mapping table, but it basically tells us that when your sending systems send a very specific value, this is what that value means. So I think to kind of give an example, hospital A might send FE for female, hospital B might send F for female, maybe hospital C sends X. One could probably assume that FE and F are probably going to translate back to female, but when we see the X come through, we don't know what that translates back to. But with the help and having these mapping tables available to us, we're able to say, okay, great, this is what the data means when it hits our system. So we can notify and normalize the data going outbound from MyHIN for providers to easily accept and interpret the data once it hits their systems. And then last but not least, for adherence to coding standards, that pertains to, I believe it's attending provider, admitting provider, and then diagnosis information. So one of the big key things to keep in mind here is that when we do talk about diagnosis information, it doesn't have to be the final diagnosis. Working diagnosis is completely acceptable, but at a minimum, those healthcare professionals that are receiving those ADT notifications from MyHIN will want to know why that patient was admitted to the hospital or even had any sort of event at the hospital. So the current threshold for each of those 3 sections is 75%. What that means is that if an organization is participating in the ADT P4P measure, they have to make sure that they are sending data in each of those sections at least 75% of the time. Therefore, if your overall conformance score is 75% or more, your organization is considered to be in conformance, and you will be receiving points for that quarter. For any reason, if your organization does fall out of conformance from like a month perspective, you'll be notified, and Blue Cross gives, I believe, a leniency of 30 days for your organization to get back into conformance. So it's kind of one of those things where you want to measure on a weekly, daily, monthly, at a minimum a monthly basis, but making sure that, again, you're not only transmitting those ADT notifications to MyHIN, but also that you're remaining in conformance. That second area, part of that key measure, was transmitting or sending the CCDAs to MyHIN. There are no threshold requirements for sending CCDs today. However, participating hospitals will earn 3/4 of a point per quarter for sending those CCDs to MyHIN. So what's currently happening is that Blue Cross Blue Shield can be evaluating the CCDs for content. And then similarly, what we saw in the past with ADT is that they push forth a recommendation to say, okay, we see that these specific areas within the various CCDs are populated the most. Some of these segments were populated a little bit. These sections never seem to be populated at all. And that's kind of how they determine those thresholds. So they take into consideration what your systems can do, the nuances of the systems and everything else, and then they put forth those recommendations. Now, what I've seen in the past, especially for peer groups 1 and 4, pertaining to ADTs, what Blue Cross puts out into the ether in terms of the threshold requirements doesn't stay the same every year. They do make adjustments, especially if there's a group discussion where the team gets together and says, you know, we just can't do this, and here's all the reasons why we run into these limitations of trying to meet this measure. Blue Cross is happy to have those conversations too. So keep in mind that as you're going through this, you might feel like you're going through it just within your hospital or your health system, but you're going through it together as a group. So lean on your other members within your peer group to be one large voice versus, you know, little individual voices. And then last but not least, the third measure was sending those labs to MICAH. So this one's just a little bit different. While there isn't a threshold established yet, the first quarter your organization is going to use for implementation purposes. So that means you have the full 3 months to send and, you know, or to work with the onboarding team to send the labs to MICAH. I can tell you it doesn't traditionally take 3 months. So truthfully, I'm not sure what the intent was behind this specifically for labs, but they're not going to award you points for that first quarter. However, subsequent quarters that you do send to MICAH is where you will be earning that 3/4 of the, or the 3/4 of the 1 point. Additionally, aside from what's available in the P4P program, there are a handful of other opportunities for your organizations to participate within MICAH's network. So you'll see that the first half of what's listed here is public health reporting. So if you can recall what Joanne had mentioned earlier, MICAH is essentially the gatekeeper for electronic reporting to the state of Michigan. Simply put, if you go to the state of Michigan and say, hey, I want to send you data, they'll actually redirect you to MICAH. The only way that you can transmit data directly to the state of Michigan is through manual reporting. And I think times are changing where we don't want to have a resource assigned to sitting at a desk where triggering those messages, you know, every minute, every hour, whatever they may be. So we have a handful of public health reporting, data exchange solutions or use cases that your organizations and your clinics, your provider organizations can participate in. And then we also have a handful of other options available as well. So we can work with you if you decide to send more than just lab results. You want to send pathology results, radiology results, transcribed documents, you know, aside from things like ADTs and CCDs, and similarly enough earlier too, Joanne had mentioned a couple of those products that we have. So My Gateway, Care Convene, as a telehealth option, Referrals Plus. You know, we're also offering query-based exchange now in conjunction with being able to query a couple of organizations through eHealth Exchange. So there are a handful of other opportunities that your organizations can take part in. And I would be happy to connect with you on it. I know Joanne would be as well. And if you want to dive a little bit deeper, there is a specific section on our website dedicated to all of our offerings where you have access to further documentation to learn a little bit more as well. But this list isn't comprehensive. I did just want to put some of the larger known use cases out there, but I think we have at least 30 different offerings that you all can take part of. So with P4P and conformance, one of the big things that we keep talking about is data quality assurance, or DQA. So, excuse me, I think, you know, in super layman's terms, we really want to avoid garbage in, garbage out. Now, that's not to say that I'm calling the data that comes into MICAH garbage, but we can take so many different measures to enhance the data that does flow into our system. And a perfect example of what I'm talking about is what you see on your screen. So this on the left-hand side is a snapshot of what conformance used to look like back in April of 2015. And on the right-hand side is what the conformance scores looked like in December that same year. So as soon as your organizations begin sending data to MICAH at a production level, MICAH doesn't disappear. We have many tools and opportunities to show you what your conformance look like, especially with our My Gateway conformance module. You can have users log in and actively review what your conformance scores look like. MICAH can help advise, you know, areas where you might need to pay attention to. We have opportunities for individual users to download things that we call fallout examples, but really it's being able to download messages that don't meet conformance requirements. So you can take those back to your teams and say, hey, we're not populating our AO1 notifications with the first name. Why aren't we doing that? And you can make those changes throughout your organizations. I've seen it done, and it's amazing to watch. But yeah, we have resources that are available to help you get you into conformance. And so you can maintain conformance and you continue to earn those incentives through the Blue Cross Blue Shield P4P program. So keep in mind that those two screenshots that I just shared were from 2015. And so when I just mentioned the My Gateway Conformance module, what you see here is exactly what I'm talking about. This is what a user will see when logging into the conformance module. So you'll see here where I was talking about the routing data at the very top, where you see normalization and mapping field data. That's the mapping table section, right? And same thing with the mapping rates underneath. And at the very bottom was the adherence to coding standards. So you can go through and check and see where your organization is in conformance for each segment that is being scored by Blue Cross. But again, really simply stated, what you can kind of ignore, I'm using air quotes when I say ignore, is the green areas and focus your attention on those red areas. So even though most of these areas are still 100%, we want to pay attention to our overall conformance score. So we know that my organization is above the 75%, but only by 5.5%. So maybe it's something that we continue to look at and monitor. And then you can engage and work with MICAH to say, hey, these are some of my problem areas. Is this something that you can help us with? And yes, absolutely. We can give you some sort of guidance depending on how your conformance scores look. Any questions before we continue for the last couple slides?
Yeah, I think I'm having like a side chat here, and there was this question. Oh, sorry, Debbie, let's go back to the percentages are based on PG 1 through 4, correct, Megan?
That is correct. So let me see if I can go back here on my slides. The computer's being finicky. These scores here, yeah. So if your organization, well, actually, let me clarify here. If your organization falls within a 1 through 4 peer group, your scores here will be reflective of your specific peer group. If you are a peer group 5, your scores here will be reflected of a peer group 5. So it depends on which peer group you fall in line with, but the big thing that you at least want to pay attention to is your overall conformance score. So those within peer group 5 have to have an overall conformance score of 95%. Whereas for the organizations that fall within peer group 5, which is probably everybody that's represented on this call today, your overall conformance threshold is 75%. So while the fields are all the same, it's just one of those things to keep back in the back of your mind where you either have to meet 75% or 95%. But if you are looking at things like labs or CCD conformance, there are no conformance thresholds or requirements set for those today. The only requirement is just to transmit the data. So you can still see what your data looks like in the conformance module. You'll just have to know, that you can work towards these things, but you're not necessarily going to be incentivized quite yet for meeting a specific overall conformance score.
Thanks, Megan. Let's see. Yeah, so there was like, sort of people, we get this question a lot. It's how do I access MICAH? And I think one of the ways that you have to think about this question is, what information are you looking to obtain? Is it for patient care? Is it for quality? Is it for healthcare operations? I think that's one of the first questions we ask is sort of like, how you work with MICAH is dependent on what information you are seeking and for what purposes. So sometimes it's as easy as asking to be another user on a tool. And that's, sometimes our easiest path. Sometimes it's more than that. Sometimes it's more, well, we would like to receive this data in these ways. We're coming to the end of this, but I did want to step back for one more second and give you an understanding of how we are governed and where we sort of fit within the state, so that you can help govern us and help work with us. So Megan and I are the co-chairs with our partners at MDHHS for a group that is a part of our governance structure called MICAH, Operations Advisory Committee Council. Any one of you are, welcome, please, to come and represent critical access hospitals and your needs and your questions and your business at this council. This council then reports up to our executive leadership and to our board of directors. And we also work in tandem with Michigan Health Information Technology Advisory Council, the HIT Commission out of MDHHS. So if you are looking to engage, we have a convening for you. We have places for you. We're waiting for you. Next slide. Again, so just to give you a sense, we will always sort of go back to what organization are you working for, and how does that organization legally connect to the network? What data are you guys legally allowed to receive, access, find, and use? And we always sort of go back to our legal chain of trust. We are always checking to make sure that legally, everybody that we are working with has the right access to the right information. Again, this works under HIPAA, so we have covered entities who are working with their business associates, sometimes to cover the legal, to connect to the network. And we only share back with covered entities and trusted data sharing organizations. A lot of the work that we have been doing is, one of the questions was, does everybody participate? And we want the answer to be yes. And we have found that just participating with a third-party nonprofit organization for the purposes of, making human beings better is sometimes just not enough reason. So there are other reasons. There are other reasons to participate, and one is that payers like Blue Cross Blue Shield incentivize interoperability and high quality data flowing through the network. And certainly policy levers like CMS and like those that are presented through MDHHS, those help to increase engagement with MyHIN and therefore get more data flowing for more human beings to more human beings through our network. There's all kinds of ways that you can connect with us. Each one of your organizations probably already has robust data sharing with MyHIN. And you probably already have account managers. One of the things that we would basically be doing is to say, okay, here's what we're already doing with your organizations. Can we connect you also internally to the people at your organization who do this? And how can you send or receive, access, or find data or critical clinical information, on your own? What information are you looking for? Is it for patient care? What information do you not easily have access to? Are you asking people for all the time or spending time looking for? It could just be that we have it. Also, what information are people waiting on you for? Is there data about your patients that needs to make its way out to providers, and more even now to other service providers like community-based organizations about patients? How are you supporting coordinated care? $12.55. It's been a lot. I have efforts. What are efforts taking place to promote the availability of this information? Debbie, I really like this question. Are you saying, like, how come we didn't know about this, and why don't more people know about this, and how often do you tell people? Is that your question? Because we try and do it as much as we possibly can. And if you didn't know about it, then we have to do a better job. Clinics use this information. Emergency departments use this information. Information is stored in our clinical data FHIR repository, which we are working very hard to update. And information that is specifically meant to be shared for public health reasons is just passed through. So we are both a pass-through, and we have data stored in clinical data repositories to be able to be used to access, find, and use.
All right. Are there any more questions? I mean, this has been great. I mean, I think there's like a lot more information than what we know is out there, as from my standpoint anyway. And I think that would be the same for many of the personnel at the hospital. Doesn't look like there's any more questions. I did save the chat, so I can send that out as well to everyone. But I want to thank Joanne and Megan for all the great information and just taking a really deep dive. I didn't realize how much different data points that were out there with MICAH. So
you can reach out to me directly, please. I'm happy to help you cross back to sort of like, how are we participating? What are we doing? We have monthly, thank you. We have monthly webinars, we have newsletters, and we could, if you think that this is really good information and more people should know about it, please connect people back to us, and we will keep telling everybody what we do.
we will definitely do that. Thank you so much.
Thanks for having us.
Thank you.